Joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on June 13, 2022. Do you have a second?
Second?
All in favor?
Yes.
Anyone oppose? Anyone abstain? The motion carry. So we now have an action item to consider for presentation to the board. Ms. Deborah Brown, please read the resolution into the record and proceed with the presentation.
Certainly, although my language is gone. Thank you. Resolution to adopt 2022 Community Health Needs Assessment Implementation Strategy Plan, adopting the name of New York City Health and Hospitals Corporation Board of Directors, an implementation strategy plan, an ISP, prepared for each of NYC Health and Hospitals 10 acute care hospitals over 11 campuses, and for the NYC Health and Hospitals Henry J. Carter Specialty Hospital and Rehabilitation Center as a supplement to the Community Health Needs Assessment, which was approved by the board in June of directors in June 2022. Shall we? Thank you all. I know many of you have been very involved in this process, and as ever, we appreciate your support. I'm going to turn to my colleague, Okenfe Labardi, our Senior Director of Community Affairs, who is leading much of this work day to day. Please.
Thanks, Deb. So after um, almost 9 months of work on this project, I think we are all happy to be seeing the light at the end of the tunnel with this project. So, I mean, first of all, I just also want to thank Deb and the entire team that has worked on this, Chris Filippo, Will Bonyen, Imam Musani, Rachel Larkin. So everyone has been really involved in this project, and of course, our entire facilities. They've also been on board. Our entire CEOs. They've been really of tremendous help to this project. Um, so supplement to the report, the community health needs assessment that was passed in June, required by the IROS to work on an implementation plan, which basically is talking about everything you spoke about in June that you put on paper. How are you going to implement it? Uh, then you're looking at the FY 2022 CHNA, which define the community served, assess the community's priority health needs from community input, and then on the implementation strategy, from FY22 to FY25, which is a 3 years time frame as set by the IROS in terms of what we need to look at and what the implementation strategy needs to be. Next. Let's skip one more. Next. Okay. So from the 2022 CHNA findings, we came up with three, well, not us, the report had three priority health needs, which was improving health equity, priority health need again, fighting chronic disease, and of course, facilitating access to resources. And under each of the priority health needs, you see the priority areas that were all also included and spoken about in the report at length. Next. And so after the board approved the community health needs earlier in June, the team took a few weeks break and started working on the implementation plan. So, which is what you see here. In August, we again got the entire working group together to start looking at what the implementation plan was going to look like. We had a system-wide compilation of programs and initiatives, writing and stakeholder review, and then of course the presentation to board for approval, which is going to again come next time. Next slide. So now going a little bit more details in terms of the implementation strategy. Per the IRS requirement, looking at the goals and the tactics of each of the priority health needs area and going a little bit more detailed in terms of addressing existing health equity issues, health equity challenges. In terms of the bullet point, you have partner with the community to offer program and services that target health equity comprehensively, enhance the frequency, accuracy, and reliability of secure and respectful data collection to better track health outcomes and predict future health emergencies. So you have the goal, and then you have the tactics. Next slide. Then under fighting chronic disease, for the goal, we have promoting longitudinal integrated care for all New Yorkers to improve health outcomes. And then with the tactics, we had address lifestyle behavior change by empowering patients to move towards healthier practices. Next slide.
And just to be
Oh.
clear, I think these are examples. This is not the part and parcel of what it is.
Yes. And with facilitating access to resources, under the goal, we have improve access and service navigation, which is again partnering with CBOs and faith-based organizations to address a lot of the social and financial barriers to services. Under the tactics, we have continued recovery from the effects of the COVID-19 pandemic. Again, as a health system, we did a lot of work during COVID, and those are not work that we feel can just be easily forgotten or discarded. So we just want to, as a system, we believe that it's great to continue and build on that, on those work and services. Next slide. And of course, resource commitment. It's our belief that the system is going to continue its financial and in-kind resource commitment through fiscal year 2022 to 25 to implement the transformative initiatives and programs. The resources are going to include both clinical and non-clinical services, talking about evaluation mechanisms, community partnership, innovative solutions, as well as staff time devoted to advanced advocacy, collective work, charitable contribution, and volunteerism. So there's going to be a constant resource commitment throughout this whole process between FY22 to 25. And on the evaluation aspect, which is what we've spoken about at length both during the community health needs assessment work itself and the various meetings that we've had with all our partners, including members of the board, is how do we actually figure out an evaluation process for this, right? What is this evaluation process going to look like? So it's still an ongoing conversation that we believe, after this whole process is done, there are folks that have been referred to us that we could talk to. I know Dr. Pagan had referred us to someone, New York Academy of Medicine. We've had ongoing conversations with them. And so those plannings are still ongoing. Next slide. So this is what the front page of the report is going to look like. It's similar to the design for the that we did in June, but you can see just a lot of different pictures. And this is the strategic committee request, adopting the name of the Health and Hospitals Corporation Board of Directors and Implementation Strategy Plan (ISP) prepared for each of the NYC Health and Hospitals, 10 acute care hospitals, over 11 campuses for the NYC Health and Hospitals / Henry J. Carter Specialty Hospital and Rehabilitation Center as a supplement to the Community Health Needs Assessment, which was approved by the Board of Directors in June 2022. Can you go to the next slide? Oh, okay. I think at the last briefing meeting we had showed how how the report actually looks like and the programs that are also in the report. So I don't know if we have it here. Okay.
And then the only thing I'd think of, Kenfa, the only thing I'd add is, I think when we started this process, one of the first things that I said is we are fortunate to work for a system for which the community health needs assessment is not kind of the tick the box IRS requirement. It's the work we do and it's the work we believe in. And I will say it's been gratifying as we go through the implementation plan to evaluate what goes on in our system, what we're going to be doing going forward, that again, this is the work we do, this is the work we are proud to do. And so, it's kind of a nice sort of concretizing of that work, but it is, this is where we live. And again, we thank you for your support in this process.
Right, and to add a little bit to what Deb just saying, because it's not on the screen, we literally took a look at the entire programs that is being offered across our system. We had everything on an Excel sheet on the 200 plus program. We sent it to the CEOs, we sent it to our senior vice presidents, said, look at these programs. These are programs that are currently being offered in the system. Are these programs still in place? And are there any programs in the pipeline? And then we had some spotlight programs. And I also asked them to give us some ideas on idea programs, out of all these 200 that you think we can spotlight. Because obviously, when somebody's looking at almost a 44-page report, they're just going to potentially skim through. But there are also some of these really great programs that want them to pay attention to that's coming out of the system. So when you see the report, that's how you're going to see some of those layouts.
Thank you. I just want to open up the floor for questions. Frida?
I don't have quite, I mean, no, I think this is terrific, and I agree with you, Deb. It's sort of like where, oh, I said, I'm sorry, I don't have a specific question, just agree with you, Deb, on this is where we live, and it's great work, thank you. I assume we'll get a copy of it when it's printed, but would it be possible to report, because it's a 3-year implementation strategy, to maybe annually come and
Sure.
let us know how it's going and what you're finding and what
Absolutely.
you're doing? I think that'd be great. Thank you.
Thank you, Frida. Any other comments
So
or
in-
questions?
in
Yeah,
terms-
Jose?
In terms of the resolution, because the resolution talks about adopting the implementation strategy plan, and we're discussing it to then adopt it at the board meeting. Is that correct?
So
We are adopting it at the committee like we
committee.
normally do
Right.
for
Recommend.
forwarding
We
it.
we're recommending.
Recommending it
yeah.
for the board.
I'm only saying it because we see the summary, right? We haven't seen.
The actual
We're seeing,
report.
yeah.
Right, right. And I think this is how, I mean, frankly, what happens is it's a whole lot of work. Then it goes to the designer and then it goes to the printer to be made pretty. And so what you will get is the finished product, and we will get that, you'll have that in advance of the board meeting. I don't know if you remember, but this is sort of how it worked when we did the CHNA process. No? Yeah.
Okay, thanks.
Is that okay?
It keeps me honest.
You feel comfortable?
Yes.
Yeah, okay. Thank you.
Yes,
Any other questions, comments? I think I just have 2 comments. Again, I just want to, as you mentioned, we have seen the labor that you have put in your team on getting this done, and it has been sometimes heroic, the amount of time that you have devoted, but we can see in the end product, we saw in the CHNA, it's really very professional, very thorough, and what I really appreciated was that, and I think as Deborah mentioned, the community was the centrality. This is not perfunctory work that we need to do to fulfill a regulatory requirement, but this process has been one that you have led to look internally, kind of the soul of our system, and see how we really work towards the betterment of the communities that we work with. So I just want to appreciate that all you have done, Deborah, Kempfe, and the whole team. And I think you alluded to 2 important issues that I think, following up on Frida's comment, that we as a board really would like to know more about it and be involved, is the evaluation. Sometimes we say that, we can have all the full intentions, but how do we realize those intentions is what is important. I think that's what Frida was looking at, that we keep kind of informed of how those good intentions are realized. And the second is, and I know that we have had this conversation, is the access. It's like sometimes, I may not be a good analogy, particularly if there is a dentist in the house, that we may seem like a candy store full of programs, activities, and it's so difficult to find out really which one is the best for you or which one you like best, or most important in our patients is which one are the most impactful and necessary. And navigating our system can be intimidating for some, confusing for others, and really can be life-changing because the services that they get will really transform the life of them and their family. So I think I particularly personally would like to know more about how we are streamlining the process for access to those resources and making it more clear. I know that a lot of times we focus a lot on the website. Oh, everything is in the website. Yes, everything is in the website, but navigating a website can be a daunting realization. So I would say that those two issues, the evaluation and the access to all these wonderful initiatives and programs, I think that's something that we would like to be informed on the utilization.
Got it. Thank you.
So without that, any more questions or comments? No? So,
Just
yes.
at all the work that went, that you all did on this, and just congratulations.
Thank you.
Yeah, I echo that. So I would like to, we have the motion. I would like to know if everybody in favor, please say aye.
Aye.
Anyone opposed? Anyone abstain? No? The resolution passed. Thank you again, Kokenfe and your team. Really a wonderful work. Next, we will hear from Mr. Ziegler, Dr. Way, and Deborah Brown as they provide an update on the system dashboard.
Great, wonderful to see you all. We're presenting our Q4 FY22 strategic dashboard. This is the end of the FY22 fiscal year, as you all know. So at that point, we like to look at the different targets we have and start a conversation about updating the metrics for the year ahead. So some of the updates that you'll see here, and then discussion, time permitting, on future changes. In our quality and outcomes measures, we have met the goal of integrating our biomedical devices into Epic, so that we would love to report it at 100% in perpetuity, but we should find a new measure, and so we will retire this one. On care experience, I think we still have the core things we need to watch and improve, so we have not proposed changes there. On financial sustainability, we have increased our targets on two of the key measures we track, raising our patient care revenue and expense target from 60% to 65%, and increasing the percentage of our patients enrolled in health insurance or financial assistance up to 90% from 76%. These are two measures that we've been very pleased with our success on, and so we want to set a higher standard and hold ourselves to that. On access to care and culture of safety, we are not proposing changes at this time, continuing to try to make progress on the core measures that we have in place there. On our foundation of racial and social equity, we have met the goal of having all of our ambulatory dashboards stratified with an equity lens to race, ethnicity, and language, and so we're proposing to retire that goal, but to add in a new measure of all of our performance improvement projects, the number of which we have an equity lens applied, so that we're tracking all the improvements we're making there and making sure they are reflecting our equity goals. So those are the changes that we're proposing at this point. In between this meeting and our next one, it would be wonderful to have discussion with board members or any discussion now about new measures we may put in place reflecting some of the findings and priorities in the community health needs assessment. One area of interest to me and focus, I think, is the priority need of facilitating access to resources. We have, I'd say, good measures in our dashboard currently of our efforts on health equity, of our fight against chronic diseases, but looking at areas that we could track, an illustrative and powerful example of how good a job we are doing connecting our patients to resources that are not necessarily traditional health resources would be important, be it food navigation, be it housing. There are many different programs we have, so picking one that would be an important thing to track is on my mind, but welcome feedback from the board on future measures to add or adjust.
Matt, if you will allow, since you presented at the high level which one you want to retire, which one you want to add, before you go into the details of each one, can we open it up for the board members to ask any questions or have any
Absolutely.
comments? Any questions, any comments? Sally?
We could talk about it when we get to the EPIC enrollment, but we talked about finding a way to quantify and reflect somewhere, and this may not be the right forum, the actual usage of EPIC. And we always think
Had the
alike, and
same
then she always goes,
question.
yeah, the actual usage of EPIC. So that's just an open question to think about how you get the data and then where you share it.
I think excellent point. We have certainly one on our patients' utilization of MyChart, right? We track that and we can look at the amount of communication and utilization of MyChart back and forth between providers and patients. I think we have also looked at or thought about providers' use of Epic, right? Of standardized order sets or things like that. But thinking more about which of those we might pick or put in here to show how effectively our providers are using Epic could be another way to look at it. So
Yeah, I think the patient utilization would be interesting because it's also keeping track of your number just went down a little bit on
MyChart.
Epic MyChart utilization, but I mean they go together, right? If you're
Yeah.
not getting answers, you're going to stop using MyChart.
Exactly. Exactly.
I think some of it might have to do with how much people are getting tested for COVID as well. So some people only used it for COVID results. And if you're not getting tested as often now, or you're just using rapid tests at home, you might not be logging into MyChart. And so that as they kind of time out, it's falling off. But Sally, I think another, besides kind of like the standardization of order sets and kind of the patient safety things that come with that, things that we've discussed on Friday is some of the fatigue that we're getting, right? If you're just using Epic out of the box, it's a lot of clicks, there's a lot of alerts, right? And so having a conversation with our CMIO, Dr. Boughton, he's talked about having a committee that's going to review all the alerts, and if it's never acted upon, can we remove those? So that work was paused, but restarting in February. Some other systems have done like a 1 billion click reduction initiative, right? So looking at workflows and saying, should it be easier to order a flu test or a flu vaccine? Why does it take 13 clicks when it should just be one if it's flu season and they don't have it yet, documented? And so I think that's kind of the evolution of Epic. It's great to get everybody onto it. Now we can share a lot of information, but are we reducing kind of the burden on our providers and our nurses for documentation within Epic and really make it user friendly? And so we can think about that as a wellness thing as well, right? How much time are people logging in at 9 p.m., like my wife does to sign her charts from that day, right?
It's a bit of an irony that the standard measures for patient use is being on it more.
Right.
But for providers, you actually want them on less. I mean, right, because part of the problem with Epic, and it's been more for the burden of Epic is less so in the inpatient area, because people are constantly charting. It's the outpatient area where people have 20-minute visits and have to do things like reconcile all of the medicines that somebody is on and make all of the orders. So that's what leads so many outpatient doctors to be on Epic after their children go to bed, because it's almost impossible to get it done during the visits. So what Eric is talking about, the various customizations that allow you to work with fewer clicks, is what people are working on. And amount of time providers are on is actually a major predictor of burnout. The more hours providers spend on Epic, the more burnout. One of the other interesting things is that women doctors, probably consistent with the data showing women make better doctors, spend more time on Epic, which is thought to be a sort of conscientiousness factor, that they're more conscientious, which makes them better doctors, but means more time on the computer, which makes them more likely to burn out because of the amount of effort that it takes to, always be reconciling the information on the chart. So But I like the fewer clicks initiative.
Yeah,
think
I like that
makes
too.
sense.
So Eric, that is something you are tracking and able to then work with Epic to adjust and,
We're still kind of in the introductory phase of like pulling together the group on it between wellness and between CMIO and CNIO.
right,
But it is definitely something that we want to pursue in this 2023 probably.
yep. Interesting. Thank you. Very interesting.
Thank you. Any other questions? Jose?
Just a quick comment on going back to this issue of facilitating access to resources, and I tend to think about it in terms of the healthcare resources and then non-healthcare resources that impact healthcare in the future, right? And since you are working with the ACO and I've seen that like Medicare Advantage plans that do Medicaid are going to be now required to track social determinants and health-related social needs. Is there a way, I mean, you may have already measures that we could use for that you are going to have to track anyway for a subset of the population we serve. So
Sure, yeah.
maybe dig into that, yeah.
The social needs screening, I think, is
Yeah,
that where you're gonna.
and I think there is a reason why this, what Ken Fay talked about came through this committee for just that reason, Dr. Pagan, because there are so many measures and, the time and thoughtfulness that goes into that. We want to make sure that they're applicable across the board.
So the comment that I was going to have was that, and then connected with the intersection of like, we work really hard on racial and social equity, the dashboards, and the equity lens. So I always tend to think about like, do we have a good indicator to track access? And then is that indicator hitting the same percentage across groups that we may be concerned about?
Mhm.
And then you get both.
Okay, yep, excellent. I think we can cut our access measures now on racial, social dimensions. So presenting that or beginning to look at that as a progress measure could be an important adjustment as well.
Fanny, can I just make one quick?
Yes.
So of course I like to see our financial sustainability targets going up. But I did have a question on the patient care revenue over expenses. There aren't a lot of comparable systems or peers that we can look at, but do you have any sense of, well, one, is the way that we calculate that number would be common to other, entities? And is there some kind of comparable information in how we, like 65%, we've moved our target from 60 to 65. What is that based on or driven by? And
Yeah, I think truthfully it's driven by the improved performance that
That
we've
we
seen
keep
in the
perform-
past
Right.
year. When we looked at it and developed the measure several years ago, we had bounced around pretty significantly, and I think we're in the 50% range roughly. And we would have to really look at just other public systems and if they report and cut their data this way, because it's really us trying to back out supplemental revenue streams
Right.
and subsidy from the city. So I haven't seen another measure exactly like this that's comparable, but it would be at other public systems and probably I think like a CFO to CFO discussion of if you cut your data like this, LA County, San Francisco, Chicago, Dallas, what would it look like?
Right.
And I think that that's probably a good discussion to have. We have to stick together as public systems and learn from each other. But those I think would be the only ones that.
It wouldn't be any meaningful at all, right?
Otherwise, the closest thing is kind of
Our
I
performance.
guess EBITDA margins at a
Right.
for-profit or nonprofit system, and that's just so skewed.
So
that
different,
it's,
yeah.
A challenge, but.
Thank you. If it were easy to do, but not critical, so interesting to know.
I think it would be
We
good.
could benchmark to other major public systems using more standard ratios. We just wanted to take a look at that.
Right.
But this really is tailored for us.
For us, yeah, very much so. Okay, thank you.
Thank you. Sally, you have another question?
If it's okay to follow up on Frida's question, I still struggle a bit getting a grasp on our patient flow and the impact on revenue. So we have uninsured patients, we have insured patients, we have New York Care patients, some of which may be insured, most of which probably would be uninsured. We have primary care patients that we definitely have recorded as primary care patients, but I'm sure we have lots of patients that come into the ED that end up just being one-shots and not signing up and being a source of where you have to provide subsidy. So I'm trying to think of all the flows, like the patient flows, and where you would reflect when you look at revenue, uninsured came through New York Cares, insured came through New York Cares, or test and trace. Do we sign them up at test and trace? Do we get revenues for test? I mean, I know we get it from the city, but do we also earn any revenue from that? You know what I mean? There's so many different streams and have different revenue implications that, like if someone says, how many patients does H&H have? It's a very complicated question to answer. Or how many how many patients actually pay for their services? Just difficult questions to answer. That's one that kind of sticks out for me.
Right.
Sally, one part I can make easier. In big numbers, we see 1 million unduplicated clients a year, and probably about 300,000 are really our primary care patients.
Right.
I mean, it changes, but
Right.
big numbers, that's what it is. The revenue, though, as you say, I mean,
Yeah.
putting aside us, how perverse all of the various, health insuring ways we pay for care are.
Right.
From, medicines that are approved, not approved, special prior authorizations and authorizations for surgeries, and that, I don't, if you really try to,
Yeah.
graph out every plot, I think what we most want, and John and Margie and her staff have been very good at this, right? We want them to approach each patient with the idea of what is a valid source of revenue
Right.
for this patient, right? And, can we identify, for example, Matt and John were working on the new immigrants that were coming, okay? So there's the standard, put them in NYC Care, but that's really a care plan. There's no revenue attached to
Exactly.
that, really.
Exactly.
But at the other end, there is disproportionate share hospital dollars if they were in the hospital, but that wouldn't count in the outpatient area.
Right.
And they were working on whether or not there's federal resettlement dollars.
Mhm.
And they might turn out, if the federal elections pass and there's a will to help us, there may be FEMA dollars, right? Depending upon whether
Right.
so,
Yeah.
I mean, I don't, the goal, and, I have felt, even if we don't talk about this explicitly, I've certainly felt that this is the will of the board. First, we provide care, right? And we provide whatever is the appropriate care to the person. We don't always have all of the bells and whistles. We don't have robots at all the hospitals. We don't always have the most modern equipment, but we give everybody the best we have.
Right.
And then on the back end, we try to figure out how to get the maximum amount of money. But we have been steadfast that we will not determine anyone's care based on ability to pay.
So is that the disconnect? There's a little bit of a disconnect between increasing our patient. We're going from 76 to 90% on financial sustainability, but our patient care revenue only went from 60 to 65% for insured. We wanted to take insured from 76 to 90%. Is that the right figure?
The 76 to 90 is either insured or on financial assistance. So it's really a measure.
Revenue produced. I mean, it's revenue for the hospital, but the patient care revenue only goes from 60 to 65.
Right, it's a much larger denominator, and the financial assistance is not necessarily a revenue generator, right? So if we have the 76 to 90 is really a measure of how many patients are we interacting with and really engaging in something. But if we enroll them in NYC Care, it's not a major revenue generator to
Right.
the system. It's only a revenue generator really if they're
But you
connected.
said it's increasing the number of insured, didn't you, from
It
76?
does increase the number of
But
insured.
Sally, remember too that in New York State, emergency Medicaid
Right.
will pay even for an uninsured person in the hospital, which is your biggest cost things.
Right,
So you might take care of 50 patients in the outpatient area who don't together create a bill the size of one patient in the hospital, right? Because hospitals are, so expensive, the care. And even if you qualify, whether you qualify the person or not, they're going to get the emergency Medi-Cal. Once Medicaid, I say, I'll never stop saying it. Medicaid, too many years of saying Medi-Cal. Emergency Medicaid in New York.
Right.
So, but I mean, what I think is so nice about the 90% is that we used to have a system where people said, oh, because we take care of everybody, it doesn't matter whether or not you have insurance or not, you just go in.
Right.
Right, and then we were losing money because there is no emergency Medicaid in the outpatients. And the patients were losing because if we do qualify them for insurance, they have way more choices for pharmacy, right, and they get other benefits that we don't otherwise provide. So what I see it is we went to a system where pretty much, you just go forward, you have insurance, good, you don't have insurance, good, to really engaging with everyone. What are you, Sally, eligible for? Let's go through what your choices are. And so they've gotten up to 90. I don't know how much, or the goal is to get it to 90. I don't know how much higher. There will always be a certain number of people who do not wish to engage. They don't want to tell you anything about themselves, and or they're in for, a very quick emergency, visit. But we want to engage with people. We don't want to bill them, but we do want to get them qualified for everything they're eligible for and convince them that it's good for them, right?
Okay.
Any other questions, comments? Thank you. Matt?
Great. So Eric and I will just run through the different trending measures. Eric, the first two are.
Yep. So if we go to the next slide, please, to slide 30. Yeah, there we go. Okay, so these are the positively trending quality and outcomes and care experience data elements. So we saw a 0.1 per 100 care day improvement in our post-acute care all-cause hospitalization. It's still not at goal of 1.0. But is trending in the right direction. So there's less times that we're sending residents to a hospital to be admitted. On the care experience, we saw a modest improvement of our overall rating for inpatient care from 61.8 to 63.2%. Target is 66%, so it's improving but not yet at target. A lot of care experience initiatives underway. We're next month going to celebrate our care experience competition across the system. So units that had the biggest increases for overall rating, for communication with physicians, communication with nurses. We're actually inviting for a luncheon here at 50 Water to celebrate their wins and hopefully create some friendly competition so others will want to win the next time around. Ambulatory care also improved 3.4% for recommend this provider office. So those are all very promising. Matt?
And then on our some of the positive trends in our financial sustainability, the percent of patients that we are engaging, with the measure we were just talking about, increased from 87 to 88. So we are within sight of that 90% target, but continuing to make progress on that will be important and challenging. The percentage of our Metro Plus patients' costs and spend that is at health and hospitals increased from 42.5% up to 44%. the closest we have ever been to our target of 45%, which is a continued inching forward on a very big denominator, but a sign of our work together and integration. On our accounts receivable days per month, we're making steady progress in driving that down. Some is driven by some system changes and frankly, name changes at some of our hospitals that has delayed some of the bills going up, but we're continuing to drive forward on the progress improvement there. And then on the big enterprise data center migration project, it is on track. We're at 50% of the 2-year project, and all of the milestones through Q4 are complete. Eric?
So for access to care, our goal of 95,100 e-consults, we've exceeded and also increased from the last quarter from 100K to 107,000. For NYC Care, also a big win for the system. What Dr. Katz was talking about, those who truly cannot be insured. We're up to 113,180. It's 3,000 increase from last quarter and above the 100,000 target there. Unique primary care patients also exceeding target at almost 414,000, target being 405, and a 14,000 increase from last quarter. And then something that we were worried about might be a little bit of a fall off, now that COVID is waning a bit, was our wellness encounters, but we actually saw an increase from 1,100 to 1,400, well above the target of 600. And so I think a lot of this is, best practice that's been incorporated at our facility level. They don't want to see these H3 debriefs, these wellness rounds, wellness rooms go away. And we also were able to pilot wellness directors with the support of Deb and the entire COVID-19 philanthropy group. Frida was on that as well, and they're working out really well. A lot of CEOs have already committed that they were going to incorporate them into their budget after this trial period, so that's very good to see.
Eric, can I just ask a
Yes.
question? Sorry. So our target is 600, and we're exceeding that.
Oh, Frida, would you?
Oh, sorry. Our target is 600, and we're exceeding that, and so that's good because people are using it. But it's such a high number. Does that cause concern that maybe like things are not good, right? And is that it's sort of an indicator in two ways?
Of distress, yeah.
Yeah.
I think yes. The short answer is yes, right? We're seeing burnout. We're seeing, right, up to a 15% turnover is what Pagny's predicting for this year, double of what last year's.
15.
15.
Right.
Yeah, so there is a lot of emotional, psychological needs for support out there. Burnout is a real thing. A lot of people are like, I've done my part, time to retire, time to go pursue other dreams. I think we don't quite know what the new baseline is going to be, and that's why we chose 600, just to be conservative. But we can adjust the number as we see what the new baseline is. And then from there, from that new baseline, then it'll be easier to tell if this is more distress or, right.
But I think the good news, as you said, is the facilities want to keep it. They're going to keep them going, incorporate them.
Absolutely.
It's a good outlet, of course.
Yes.
Thank you.
Any other questions? No?
Okay, so going on to the next slide. So these are the steady ones. Hemoglobin A1C control, 65.3%, very close to the 66.6% target. MyChart activations, we touched on this a little bit. We hit a high and it's come down a couple percent at 71.3, but we're still pushing activations as much as we can, trying to get to that 75%, but also turning our focus towards engagement. How are people engaging with us through MyChart?
And then on the overall patient care revenue over expenses, we remain steady at about 75%. The new target is 65%. The reason the target is below where we are currently is we are building in some potential for the end of the public health emergency to have an impact on that number. And so we want to see how changes in some of the COVID-specific policies on rates, on Medicaid recertification, impact that number, and the 65% target is where we have stayed for the quarters ahead.
And then looking at some of our negative trending, I believe the first one with discussions with Dr. Barron and Dr. Fatal and OBH, this might be a data definition discrepancy. It's flat. This should be a steady metric at around 50%. But the percent left without being seen in the ED going from 3.9 to 4.4%, that is real. This is due to overcrowding of our hospitals. When there's no room for patients upstairs, then they backflow into the emergency department and you're holding admitted patients, which means less space to see new patients, and then people getting frustrated with the wait and leaving without being seen. This is our new baseline post-COVID. It's not COVID-driven. It's not flu-driven yet. This is our reputation improving in New York City. This is chronic diseases not being managed through the pandemic, leading to worse health outcomes. This is social and economic kind of distress in New York City, making it harder for our long staying patients for us to be able to discharge out of the hospital. So the way to address this seemingly emergency department metric is actually to address flow out of our hospital to post-acute facilities, to home, and there is a lot of work going on around length of stay and supporting that. But I think this is something that's here to stay, as well as the seasonality of flu season.
On the post-acute accounts receivable, this number has bounced around a little bit quarter to quarter. We are about consistent with where we were a year ago, but up from the prior quarter. I think that the team continues to make progress, and their overall budget is in good shape, and looking to, we hope, improve quite meaningfully with the state's policy change around individuals over 65 who are undocumented being eligible for state-only Medicaid dollars, which we're hoping to see in 2023.
Okay, so on the racial and social equity measures, this is one that we're still honing and perfecting. This first one, percent of new physician hires being from underrepresented minorities in medicine. From the latest data for this quarter that we're discussing, 42% identified as female, 0.3% as non-binary. And then for the underrepresented minority ethnic groups other than white, Asian represented 14%, Black or African American 4.9%, Hispanic or Latinx 2.1%, American Indian 0.5%, Native Hawaiian, other Pacific Islander 0.3%. And so we'll keep tracking this. This is, I think, a little bit of a medium to long-term lagging measure as well. Dr. Allen, our Equity and Access Council, with Drs. Natalia Sineas and Nicola Davis, working on things like Mosaic to get high school students, to get medical students, to get residents to come engage with H&H from these underrepresented minorities, learn about our mission, get excited about the mentorship, and get excited about taking care of these patients. But this is not something that, it's going to happen overnight. But the programs are making a lot of progress.
Can I comment on this one?
Yes, please.
So, I mean, because the target is to increase the flow, right?
Yes.
I wonder whether we should think about how to work even with the physicians that we have that belong to the different groups that we are trying to recruit from, to get them engaged, use them as a help, see if they're interested in serving as ambassadors for the system, coming up with ideas like that may make the system more attractive to. And I realize that there's a lot of competition out there, so everybody's going for the same pool of physicians, right?
Exactly. Yeah, and it's been a dwindling pool over the last, I think in the 70s, there were more Black or African American residents than there are today in training. And so the pool has been dwindling, and we're all fighting over, right, trying to capture as many of those same underrepresented minorities.
And also,
I don't know if Michelle, you want to come and talk. We're partnered with Mentoring in Medicine to do some of that role modeling and getting young.
and also, Eric, working with the professional organizations, National Hispanic Medical Association and so on, for each group has one that they have an impressive list of members that I don't know if we can reach out to them or give talks to them about it, about the system. I don't know if they allow that, of course, because everybody has a job, but yeah.
So the National Medical Association, the current president is actually maternal fetal medicine at NYU. So we went to the last NMA, as you know, it's African American physicians, and we plan to have a table at their next meeting next year. Don't have a direct connection with the Hispanic organization as well. Fenny, maybe, I know you may have, so we'll work.
Get you connected to them.
Yeah, so we can work with you. And we should probably, Kalisha or Jose, have the Mosaic team give a presentation to the board of directors so that the board is really cognizant of what's being done in this direction around recruiting minorities. The other thing, which I just realized, there are facility-specific differences in demographics. So if you look at a facility like Coney Island, where about 4% of their patients, maternity patients are African American, and you look at Kings County, where 86% of their patients are African American, we are not homogeneous even within H&H. So it would be really be best for us to look and share with you the facility-specific data that we have on demographics as well, and the providers at each of those sites, if the providers represent the community. So Coney Island may have a Russian community or a South Asian community. Kings County has an African American community. I think we should really look at that reflection, facility-specific. That's just a thought.
Yeah, and John is also partnered with the Mosaic team talking about funding these rotations of medical students from historically black colleges and universities, partnering with University of Puerto Rico, as well as residents from from their hospitals to do a rotation here. So paying for housing, paying for food while they spend a month with us. And then loan forgiveness is another thing looking into. So can we attract graduates with some perks, such as loan forgiveness? But yeah, definitely warrants a full presentation.
Thank you. I just want to do a process check. We're trying to, we had like a lot of meetings, so I don't know if there are certain slides that you can skip or
I
whatever.
think we are at
I
the
have a
end here.
question about the
The
previous
only.
slide.
Oh, okay,
I'm
so
sorry.
we do have a question
Yeah,
first.
when you were speaking about the flow from the ED to the floors, and then the floors out, I noticed you didn't mention staffing at all. And usually that plays a huge role. And what issues are we having there, and what are the titles that are having the issues? Because I know when it comes to discharge, providers play a huge role in that.
Yeah.
And if you don't have the providers to help discharge, it all falls apart as well. So
Yeah.
if you can
I think
enlighten us on that, that would be helpful.
The short answer is all of the above, but probably the most painful ones, nursing. You can't open units without the safe staffing, hospitalists, and so they're experiencing the same sort of burnout. And then the staff that really help us with discharge planning are care managers, case managers. Sometimes we need social work, and even sometimes it's a physical therapy and rehab, right, for them to be able to get that evaluation before they can go to a skilled nursing facility.
I would add, Eric, PCAs, because we could open more skilled nursing facility beds if we had more PCAs, personal care attendants. So it is, as Eric says, it's at every level of, and we have openings everywhere. Yvette is great about job fairs. And in some of the cases, it isn't about our compensation compared to others. It's just about sheer workforce. They're not people right now. It's as others have talked about. It's been a very hard time to be a healthcare worker, and a lot of people are taking time off and saying, I need a break from this. I got through it, and now I just want to, I've people who've gone into retail, people, right, who've moved to, less expensive places with whatever dollars they earned. It's just really, really difficult.
Yeah, and what they consider less risk after this pandemic. But here's my thing. When I see the work that has gone into H&H and being a Brooklynite and knowing how people like ran from Kings County and now people are coming to Kings County, what a shame to lose someone, to have someone come to your ED in an emergency, have the opportunity to capture them, have a follow-up appointment at one of your clinics, or want to come to that clinic, and lose them at that moment, to not even stay in the ED. That's a loss.
Yeah.
That's a loss for potential and what we're trying to recover
I
again.
agree.
So I mean, whatever I think that could be done to help change that cycle has to be done.
Yep.
And I know this is not just an H&H problem per se, but this is a problem that we should try to figure out how to solve so that we can capture the patients and keep them coming and keep them well, because you want to move them to your outpatient.
Absolutely.
So what a loss.
And there's a whole kind of portfolio of performance improvement projects and initiatives, including using some agency staffing, knowing we're getting into the fall, into flu season. We expect a surge on top of this surge. And so trying to be proactive and get ahead of that.
Thank you. Any other questions? Sally?
On the quality of care metric, it seems to me that everything from someone having a bad attitude to someone really, doing poor work, gets lumped into the quality of care metric. And I know that most of the hospitals break down what the quality of care complaints were about. And I guess we're focusing on, and not surprisingly, the personal interaction, the degree of sense of that they are being treated well, just on an interpersonal level, is high there. I guess that's our eye care work that we do and try to emphasize, because it seems a tough metric to budge.
Yeah, but Sally also, I 100% agree. The care experience is definitely what patients and their families feel is often how our staff are feeling about, right, the organization that they're working about. So outside of medicine, right, Marriott, you take care of your employees, they'll take care of your customers, the business will take care of itself. How Southwest takes care of its employees and that they get high ratings for that airline. We 100% agree, right? Who would you rather see a provider and a nurse who are well, who are engaged, have a full tank of empathy, right? Love what they're doing, purpose, passion for the job, or somebody who's burnt out, who doesn't feel like the organization cares about them. And so our whole workforce wellness strategy is to refill people's tanks so that they can give their best to patients and families that they interact with. And right, all the extra stuff that we're doing around Plaintree and these competitions, that's not going to work if the workforce is burnt out and disengaged, right? And so I think it's all kind of captured in that. You're more likely to be friendly, nice, and empathetic and kind towards your patients if you're not feeling, right, negative feelings towards the organization.
Right.
Thank you. So, Eric, if you can.
Yep, I think that concludes our presentation. Thank you for the time.
Thank you. We appreciate it. Any other comments? Any other questions? No? Any old business? Any new business? Being no further question, this meeting is adjourned and give it to finance.
Thank you. This meeting is no longer being recorded.